Hello, this is our second video that is going to focus on a little bit more on lung volumes, on looking more closely at the air that we're bringing into our lungs. And then we're also going to talk about lung compliance, which is the idea of how distensible the lung is and what that means for lung function. So let's start off talking about lung volumes, where we've already talked about tidal volume. We said that is going to be how much air we're breathing in or out during a normal breath at rest. So we also said that was about 1/2 liter. So here is a graph of different lung volumes where here at the beginning the subject or patient is breathing normally with just normal tidal volume up and down, air in and out. And so then at this point they're told to breathe in and then breathe in absolutely as much air as you can. So if you take a normal breath and then you could even fill your lungs even more. And so that extra air that you can add to your lungs above your normal tidal volume is called the inspiratory reserve volume. And that's what's shown right here. And that's this portion of the curve. So most of these values can be measured just with a handheld spirometer. So it's very easy to measure these values. And these values are going to be important for diseases. These values are going to change with disease, and we'll be talking about that a fair amount. So you've got the amount you can inhale after you've already taken a normal breath. That's inspiratory reserve volume, and it helps to kind of try this out, I think, to get a sense of what I'm talking about. Then you can do a normal exhalation and then exhale even more. So in a similar way, this is going to be expiratory reserve volume. Now, once you've completely removed all the air from your lung that you can remove, so if you exhale completely, you still have air in your lung. Otherwise, your lung would completely collapse, which is very difficult to overcome because of the surface tension of water. So that air that's left in the lung, which is perfectly normal and very important, is called the residual volume. So we can put these numbers together to come up with some other capacities that are important for understanding the lung. So if you exhale, a normal exhale, and then completely fill up your lungs, so that's adding the tidal volume and the inspiratory reserve volume, you can call that inspiratory capacity. And a really important number is vital capacity. That is if you take a complete breath in so that your lungs are completely full, and then you exhale all of that air as much as you can, that determines the vital capacity. So that is your capacity that you can use. It doesn't include residual volume, but you can't use residual volume to bring air in or out of the lungs. So vital capacity is important. And then you can also determine total lung capacity, which would be vital capacity plus residual volume. As you can imagine, residual volume is going to be difficult to measure. It's possible to measure it, but you can't measure it with just a small handheld spirometer, because the spirometer is measuring the air coming in and out of your lungs, and residual volume does not come out of your lungs. We can also look at functional residual capacity, which is basically the volume of the lung once you've exhaled a normal breath. So the next slide will give you the definitions of all these terms, but before we move on, I just want to point out that these values, as we've mentioned already, are going to change with certain disease states. And one thing that you can look at is the residual volume, comparing it to total lung capacity. So what proportion of all the air that's in your lung can you not expel, the residual volume? And so there are going to be certain diseases called obstructive diseases, where it's hard to exhale. And so as you can imagine, in these diseases, patients will tend to have an increase in residual volume. Since they have problems exhaling, then they end up having more air in their lungs once they've exhaled. Versus a restrictive disease, which we'll be talking about examples of these in a minute, where for some reason you can't open up your lungs the way a normal person can, and so in that case, total lung capacity is going to decrease. So here's that slide I was mentioning where it lists these terms and their definitions, which I've just gone over. And now we're going to switch to talking about these two types of lung diseases, obstructive diseases versus restrictive diseases. And we're going to be referring to these throughout the rest of the video. So it's important to get an understanding of these because they really are helpful in understanding how the normal lung functions by comparing what happens in these diseases. So, as I've mentioned, an obstructive disease means that it's hard to expire. And that often means that residual volume can increase. Examples of this would be in asthma, when you're going to have inflammation and contraction of smooth muscle in the airways so that you're going to increase resistance. Another example is going to be in COPD, chronic obstructive pulmonary disease, which comes kind of in two flavors. Chronic bronchitis, which is where you're going to have a lot of mucus in the airways, and people can have also emphysema, or they can have both forms of COPD, where the alveoli are destroyed, and often that's because of a lack of elastic tissue, which means that the lung is very easy to open to fill, but then it doesn't have that recoil to exhale. And then you can also get collapse of small airways. So we're going to be talking more about this. But it kind of is anti-intuitive that you'd have a disease where it's only hard to exhale when you'd think the same processes would also affect inhalation. But the important thing to keep in mind with that is that when you're inhaling, you're opening everything up. You're stretching those airways even if they're collapsed. And so in that way, you can have these processes that don't really affect inhalation very much, but what they affect is exhalation. And particularly exhalation when you're really having to squeeze out the air to get it out quickly, because that's a compressing process. And so if you already have a problem with small diameter or with something that collapses easily, then exhaling is going to be much worse and be much more difficult. The restrictive lung diseases are that the lungs can't expand for some reason, and so total lung capacity has decreased. So one example of this that we'll be talking about are fibrotic diseases, which is when connective tissue is being added to the walls of the lung, which then connective tissue that doesn't stretch, and so then that elasticity of the lung has been removed, and so you just can't stretch it as much, and total lung capacity decreases. And then there can also be conditions such as scoliosis, when you have a curvature of the spine that literally prevents the chest wall from expanding. But it's going to have the same effect of preventing a large increase in volume and reducing total lung capacity. So we're going to use these diseases to look at what happens when we consider compliance of the lung, which is going to be defined by the change of lung volume that's going to occur when you change the transpulmonary pressure. So when you change the pressure across the lung. So you can think of it as if you apply a certain amount of force, basically, to open the lung, how much does it open? How much does the volume increase? So that's what's shown here, where we've got pressure on the x-axis and lung volume on the y-axis. So let's consider a normal lung, which is the blue line, where you apply a certain pressure, the lung opens, and that continues at a pretty linear fashion until you get up here where we're starting to get a plateau. So this is going to make sense because here you've got a very high lung volume, so your lung's already full, and so you can apply a lot of pressure, but it's not going to get bigger because it's full. So this is perfectly normal, and it makes sense. So this is kind of a normal amount of compliance, which you can also think as the distensibility. How easily is it opened? Now, the thing to keep in mind with the lung is as compliance increases, recoil is going to be inversely proportional. So if compliance increases, recoil, which is the amount that it's going to shrink, is going to be changed in the opposite direction. So that's what we're going to talk about now. Where in a normal lung, you've got kind of a medium amount of compliance and a medium amount of recoil. In a disease where you have increased compliance, which is this green curve, that is going to mean that it's easy to open the lung. You can see we're applying a small amount of pressure and we're getting these huge lung volumes. So they've got increased compliance, but if you have increased compliance, that means recoil has gone down. So you can think of this as in emphysema, when the elastic tissue has been destroyed, which means, hey, you've got nothing that is trying to prevent you from opening the lung. So that means, hey, it's easy to fill it, but then the problem is you need that elastic tissue, you need that recoil to cause the air to come out. And so you've made it easy to breathe, but harder to exhale because you've increased the compliance and you've decreased the recoil. So you could think of this in a very extreme way as if I had this paper bag where I've got very high compliance. It's going to be easy for me to put air in here and expand it, but then I'm going to have low recoil, and so it's going to be hard for the air to come out. Okay, so here I've filled the bag very easily, but then the air isn't really coming out of it because it's got basically no recoil. So this is increased compliance and low recoil. Let's talk about the other situation where we would have decreased compliance, which means we're applying lots of pressure or force, and our lung volumes are not increasing very much. So it's, we've got, let's say we have connective tissue, which means that the lungs just aren't going to stretch the way that they should. And so it's taking more force, energy, pressure to get air into the lung. So we've decreased compliance, but that means that we've increased recoil so that it's going to be easy to get the air out. And so an extreme example of that would be this balloon, where it's going to take me a lot of pressure and force to open this or to fill this balloon, especially compared to the paper bag. But then when I let go, air's going to come rushing out because it's got lots of recoil. So, okay, so it's got low compliance and high recoil in the balloon. So obviously our lungs are going to follow somewhere in between these two examples, but that you need both. You need to be somewhat compliant and you need to have a certain amount of recoil for the lungs to function properly. So what is so important and what are the properties of the lung that allow us to have this compliance? And we've already talked a little bit about elastic tissue, which is going to kind of make it harder to fill it, but definitely provide that recoil of the lung. And so in emphysema, we're destroying that elastic tissue, and so compliance is going to increase. And then in fibrosis, we're adding connective tissue that doesn't stretch to the lung, and so the lungs are not as distensible, and so compliance is going to decrease. The other factor in compliance of the lung is surfactant, which we have only talked about because, remember, type 2 cells of the alveoli are going to make surfactant. They're going to actually make it in response to the lung being stretched. And surfactant is a detergent-like molecule. That's what's shown down here, where it's going to have hydrophilic and hydrophobic portions of the molecule, and that's what's going to help it reduce the surface tension of water. So that every time we breathe, since we're expanding the lung, we're having to fight or combat the surface tension of water. We're having to overcome that force. And so surfactant reduces the surface tension so that it doesn't require as much force to open the lung. So this is most easily demonstrated in certain premature babies who, because they're premature, are not yet making surfactant. Breathing, just normal breathing, requires a tremendous amount of energy for these babies. They can die from exhaustion of trying to breathe. And so it's a very illustrative example of how much force it takes if you don't have surfactant in your lungs. Luckily, babies can be treated with surfactant that can make their breathing normal until they start making surfactant themselves. Another side note is just that there are other surfactant molecule types that are important in lung defense. Another issue in the surface tension situation is that our alveoli in our lungs aren't going to be exactly the same size. And so because of that, then you have to worry about what's happening with the pressure and if it's going to be equal, because of the law of Laplace that says that the pressure in the alveoli is going to be equal to 2 times the surface tension divided by the radius. So since the radius is involved in the pressure in the alveolus, and we can have alveoli that are different sizes, that means that if we have the same surface tension in 2 differently sized alveoli, we're going to have a difference in pressure, which means that the smaller alveoli that have the smaller radius would have a higher pressure, and that air would then flow from the small alveoli to the large alveoli, which is not the direction we want the air to flow. So the amazing thing about surfactant is that it preferentially lowers the surface tension in the smaller alveoli so that the small alveoli and the large alveoli have the same pressure. So that's what's shown here. It lowers the surface tension in the smaller alveoli more, so that even though they have a different radius, the pressure in alveoli number 1 and 2 are the same. So that's another important aspect of surfactant, just based on its molecular properties, that it is able to do that. So we've talked about different lung volumes, how we can measure them, and how they can change a little bit in disease, and we'll be talking about that more in the future. And then we also talked about compliance. So that's going to be a measure of distensibility, and it's going to, if it's increased, then that means recoil is going to be decreased, so that it's going to be inversely proportional to one another. And we talked about how in a restrictive lung disease, the lung is going to have low compliance, but it's going to have high recoil. And in an obstructive lung disease, we're going to have high compliance, but then low recoil. And we'll be talking more about these 2 types of diseases in future sessions.